and screen visible? Right. Yeah, good morning, Rosh. How are you doing? So let's quickly revise what all we discussed yesterday. Yesterday we had started up with the metabolism of, okay, we had started up with the metabolism of glycogen. And I told you glycogen is the stored form synthesized from glucose, right? From glucose, and this, one second, beta, let me just put my mic. Synthesizing glycogen, which is stored in the liver and the muscle. This is what we discussed yesterday. Okay, liver and the muscle. And I told you one very important thing, whenever energy is required by the body, glycogen is broken into glucose. Now this reverse process occurs only in the liver. Okay, not in the muscle. Now can anybody tell me why not in the muscle? Breakdown of glycogen to glucose takes place only in the liver, not in the muscle. Why? Because in the muscle, glucose 6 phosphatase is absent. This is a very, very important point. Okay, so we can simply say that this glucose is forming glycogen by a process known as glycogenesis, right? Where the rate limiting enzyme is glycogen synthase. Clear? And this glycogen is broken down to form glucose. Now, what I'm trying to tell you here is in the liver, glucose is easily produced, but this glycogen is unable to form glucose in the muscle. Right. So obviously what happens is glycogen goes up till glucose 6 phosphate. Clear? So this glucose 6 phosphatase is absent in the muscle. So this reaction does not take place. And this glucose 6 phosphate is metabolized to form lactate in the muscle. Clear? And this process is glycogenolysis. Conversion of glycogen to glucose is glycogenolysis. And always remember the rate limiting enzyme in glycogenolysis is glycogen phosphorylase. This is what we discussed yesterday. And the most important point I told you, biochemistry without regulation is nothing. So I told you that insulin accelerates, because insulin is an anabolic hormone, it accelerates the process of glycogenesis. Now, how it can accelerate the process? By activating glycogen synthase. So it makes glycogen synthase active in its dephosphorylated form. This is what we discussed yesterday. Okay, so I can say that this active form of glycogen synthase is dephosphorylated, and D means removal, so it is without phosphate. Very, very important. And then glucagon. Always remember glucagon and catecholamines means I will just take the name of epinephrine. So glucagon and epinephrine, they accelerate the process of glycogenolysis. Right? How they can accelerate the process of glycogenolysis? By making glycogen phosphorylase active. So, beta, yeah, good morning, Barkha. I think you are attending my class for the first time. Yeah, okay. So it's like you are from Nigeria. Fine. First of all, welcome to India. Okay. So we have just started up with the metabolism of carbohydrates. I will just brief you the things. Okay. And if you guys have any problem like related to what all we have discussed in our previous videos, right. Okay. So this is a new topic, Barka, Basila. Yeah. Good morning, Alia. Yeah. So, glucagon and epinephrine always accelerates glycogenolysis. Okay, thank you. That's such a compliment. Yes, I am teaching there also. Okay, you've bought that course. Very good. So, in case if any problem is there, beta, so you can don't hesitate to ask me. Okay. So here I am going very slowly because I just want you people to go through the basics because biochemistry is a very interesting and a you know easy to understand subject. No doubt it is little bit volatile, but we are here to make it more easier for you. Okay, thank you so much, Alia. Right. So coming over to the topic, so glucagon always promotes glycogenolysis, which makes glycogen phosphorylase active. Okay, so I can simply say that if glycogen synthase is active, okay, means if the synthesis of glycogen is taking place, there is no question of breakdown. And if breakdown of glycogen is there, there is no question of synthesis. We can do one process at one time. So automatically, if one process is taking place, the enzyme of that particular process will be active. Okay. Now, the difference between glucagon and epinephrine is that glucagon only works in the liver. Only works in the liver. And if we talk about epinephrine, epinephrine works in the liver as well as muscle. But both hormones are required to regulate or to break glycogen when the energy is required by the body. And work, always remember, yes, works on liver and very good, works on liver and muscle. And again, I am telling you that whenever the body is in fed state, always remember insulin will work in general. So fed state, glycogenolysis is there, and starvation, glycogenolysis. Starvation, or you can say mainly fasting. Under fasting, this glycogenolysis will take place. So this is very, very important. During fed state, glycogenesis. During fasting stage, glycogenolysis. Now today we are going to discuss a very important, clinically important topic, I should say, glycogen storage disorders. Yes, very good, Alia. Fed state, generally insulin works, and fasting stage, glucagon works. So now we are going to study. No, beta, epinephrine needs ATP for conversion to what? Basically, this epinephrine is synthesized from norepinephrine, Siddharth, in the body. Their methionine is required. This we will be discussing in detail in protein metabolism. So I'll just, since you have raised this question, so I will just like to tell you this thing that epinephrine is synthesized from norepinephrine. Okay. And this reaction takes place in the presence of methionine. So methionine provides methyl group to this. Got my point, Siddharth? So ATP has nothing to do with that reaction. Clear? And ATP is just the energy currency. See, here epinephrine is working as a hormone in accordance with cyclic AMP. So it's like, hormones are first messengers and second messengers are cyclic AMP, cyclic GMP. So it's like a coordination between them. Is it clear, Siddharth? So now we are going to study glycogen storage disorders. Commonly, we call them as GSDs. Now see, if we talk about the disease itself, glycogen storage disorder means there is a disorder in the storage of glycogen. Getting my point? So how this disorder takes place? Obviously, because of the absence of the enzymes. Similarly, if I tell you about this, that C is broken into A plus B, from where it is produced. Suppose the enzyme required to break C into A plus B is absent. What will happen? There will be increased concentration of C and decreased concentration of A and B. So that is what exactly happens in glycogen storage disorders. Clear? So we can simply say glycogen storage disorders are the diseases which occur due to the deficiency of an enzyme. So, glycogen storage disorders are the diseases which occur due to the deficiency of an enzyme. So, obviously, it will lead to either accumulation of glycogen or it will lead to decreased concentration of glucose. Clear? Because glycogen, if I talk about this, glycogen is not being degraded to glucose. So the concentration of this increases and the concentration of glucose decreases. And always remember, whenever the concentration of glucose decreases, we refer that stage as hypoglycemia. Always remember it. Hypoglycemia is there. Clear? Now see what happens here is, since the diseases, or you can say the synthesis of glycogen is in the liver and the muscle, so obviously I can say that these GSTs will be either in the liver, means storage will be in the liver, or storage will be in the muscle. Siddharth beta, ho gaya clear? Because you didn't reply after that, that's why I'm asking you. Fine, it's clear then. Okay. Yeah. Whenever you understand anything, no, better just give a thumbs up to me. Okay, just give a thumbs up so that at least I will also get a, every day I tell you the same thing. So start giving thumbs up if you understand. And if you don't understand, obviously you are feel free to ask the questions. Okay. So GSDs can be liver glycogen storage disorders or muscle glycogen storage disorders. Now coming over to this, always remember that in biochemistry, most of the diseases के लिए, if we have to learn the diseases, we need to know the mnemonics, because sometimes it is very difficult, because those people who are just fresh pass out from class 12, it will be very difficult for you to understand in the starting. Once you are thorough with the medical terminology, it will be a 1 minute game for you. But before that, try to convert biochem into mnemonics. So if I talk about glycogen storage diseases, you know what is the mnemonic? Mnemonic is वो, physics, chemistry और maths में होशियार था. राइट? वो फिजिक्स, केमिस्ट्री और मैथ्स में होशियार था. You have to take just one alphabet of the entire mnemonic, right? So I can simply write like this, वो physics, chemistry और maths में is like that, होशियार था. Clear? Now this V stands for von Gierke's disease. Right. P stands for Pomp's disease. Pompey's disease also, or you can say Pomp's disease. C stands for Cory's disease. A stands for Anderson's disease. Right? M stands for McArdle's disease. H stands for Her's disease. And T stands for Tarui's disease. Clear? So these are the name of the glycogen storage disorders. And mnemonic to remember them is वो physics, chemistry और maths में होशियार था. So I can write it here, name of the disease. Dr. Sochi, friends? Yes. Okay. Barkha, are you understanding, beta? Barkha Basila. Okay. So name of the diseases are here and I'll just write the types here. So I can say von Gierke's disease, I've written number 1. So it will be type 1. Pomp's disease is type 2. You can pronounce it as Pompey's disease also because they are all nouns. So it depends on the pronunciation. So von Gierke's disease, Pompey's disease or Pomp's disease. Cory's disease is, okay, yeah, it's fine then. Cory's disease is type 3. And yes, one thing also I want to tell you people is I share this material in my group on Telegram. And daily, on a daily basis, I post some of the quotes on Biochem on my Telegram channel. So you guys can, join my Telegram channel for other upcoming, whatever upcoming event is there on Biochemistry. Okay. And my channel's name is simply Biochemistry by Dr. Pooja Johari. Okay. So you can join that. And there I daily discuss some MCQs also. So whatever topic I am discussing, just go through this and try to solve the questions. Right? Then we come over to Anderson's. It is type 4, type 5, type 6 and type 7. So this is how we term them. Von Gierke's is type 1, Pompey's type 2, Cory's type 3, Anderson's type 4, McArdle's type 5, Her's type 6, Tarui's type 7. And von Gierke's disease is known as type 1A. Right? And then the most important point which you have to actually mug up is the deficient enzymes, right? Because name of the disease, this is the chronological order and the enzyme deficient. So if we talk about von Gierke's disease, the deficient enzyme is glucose 6-phosphatase. Now don't get confused beta because you will say ma'am said glucose 6-phosphatase is absent in the muscle. Isn't it? That's what I told you. Ki glucose 6-phosphatase muscle mein it is not present. But liver mein to it is present. And in this disorder, glucose 6-phosphatase will be absent in the liver. That is why if you see this von Gierke's disease will come under liver glycogen storage disorder. Clear? So I can say that von Gierke's disease, the deficient enzyme is glucose 6-phosphatase. In Pomp's disease, the deficient enzyme is lysosomal acid maltase. Right. In Cory's disease, the deficient enzyme is debranching enzyme. I will be taking these disorders one by one, don't worry. Debranching enzyme, Anderson's branching enzyme, right? In McArdle's muscle, M for mech, M for muscle. So here muscle phosphorylase. Type 6 is liver phosphorylase. And in Tharoi's disease, the deficient enzyme is phosphofructokinase. So I can say that these are the disorders. These are the numerical name you can say, and these are the enzymes which are deficient. Clear? Now let's start up with these diseases one by one. So because the most important thing is beta clinical features. If suppose a patient comes to you, abhi right now to chalo you have not become doctors. Now if you go as a patient to any doctor, he will examine you and he will tell you to come up with certain tests. Examination, taking a history is what all features you are showing, whether you are having pain in the abdomen, whether you are having pain in any area, whether any area is inflamed also. Then he will tell you to go for certain tests, either biochemical tests or microbiological tests, right? And on the basis of these tests only, the doctor will be able to define something that maybe you are suffering from this. So if diagnosis is there, treatment can be planned, right? So clinical features are very, very important. Okay, so first of all, we will take up this von Gierke's disease. अब now see, von Gierke's disease is basically type 1A, right? If we talk about the deficient enzyme here, the deficient enzyme is glucose 6 phosphatase. So it is a liver storage disorder. Getting my point? Storage disorder. Now see what will be. Yes, very good, Siddharth. Glucose 6 phosphatase. Now see, beta, you have written G6PD. If I give the full form of PD, you know, PD is phosphate dehydrogenase. So you have to write glucose 6 phosphatase. Okay, because even if a slight difference is there in the spelling, the entire thing will change. Getting my point, Siddharth? Okay, so it's a liver storage disorder. Now see how the thing goes. This is glucose 6 phosphate, which is being converted to glucose. If I say, and the enzyme is glucose 6 phosphatase. Here the deficient enzyme is this only. Clear? So the first will be, there will be decreased concentration of glucose. So I can say that hypoglycemia will be there. Very important. Yeah, please join the Telegram group. There you will find so many important concepts regarding biochem also. Now see, if the concentration of glucose is decreasing, the concentration of glucose 6 phosphate will increase. It's clear. This glucose 6 phosphate whose concentration increases, it will be diverted. It cannot be converted to glucose, so it will be diverted to form other things. So this glucose 6 phosphate will be diverted to form lactate. Yes, Basila, you can get the lectures after this session also, because these lectures are lying on the YouTube as such. So whenever you feel like, as per your convenience, if you are having your lectures, so you should go for your lectures. After that, you can go through this. And again, I'm telling you, if you want to have an access with the PDF of this, then you can join my Telegram channel, right? So you can have an idea. Rest, if you guys take my number, so then if you have, yeah, so if you want to take my number is this is my WhatsApp number. I'll just write it. So if you have any problem related to any of the topics, you can ask me. This is my number. Right, Basila? Clear? So now coming over to the topic, so I can say that if there is increased concentration of glucose 6 phosphate, it will be diverted to form lactic acid. So I can say the lactic acid ka concentration also increases. So it will lead to lactic acidosis. Lactic acidosis is better that condition of the body when there is increased concentration of particularly lactic acid. Okay, so obviously we all know that when the acidity, when acidic environment is there in the body, the pH will decrease. And if the pH decreases, there are so many important, the entire acid-base balance will be disturbed. Okay, so we can say that hypoglycemia and lactic acidosis will be there. Up again, this glucose 6 phosphate will form pyruvic acid. As you know, increased concentration hai, glycolysis will be there because lactate is being produced. So I can say pyruvate will be produced, and this pyruvate will be converted to acetyl coenzyme A. This all you have studied. Okay. So if the concentration of acetyl coenzyme A increases, right, this is required for the synthesis of fats in the body. So the concentration of fats will increase. Or you know how we designate fats? We call them as TGs. TGs are triglycerides. I'll just write TGs here. After that, I will explain it to you. So I can say that increased concentration of glucose 6 phosphate increases acetyl coenzyme A, increases TGs. And whenever there is increased concentration of triglycerides, we call it as hypertriglyceridemia. Right. So I can say that just because of the absence of one enzyme, you can see only one enzyme is absent. Which enzyme? Glucose 6 phosphatase. But it is leading to so many other features. It is diverted to form lactic acid. It is diverted to form TGs. So hypoglycemia and hypertriglyceridemia will be there. Similarly, this acetyl coenzyme A will be diverted to form ketone bodies. Ketone bodies, abhi right now I'll just tell you, later on we will discuss them in detail. Ketone bodies beta एक ऐसी bodies होती हैं, they are produced in the body. In a normal individual also they are produced, but when the body undergoes starvation. Okay, during starvation, ketone bodies provide energy to the brain and to the heart. Clear? So ketone bodies in a nutshell are the sources of energy. Right? So this is, I can say, and whenever there is increased concentration of ketone bodies, we call it as ketosis. Right? Again, I am telling you, by just the absence of one enzyme, you can see lactic acidosis is there, hypoglycemia is there, ketosis is there, hypertriglyceridemia is there. And then another feature is this glucose 6 phosphate will undergo HMP shunt, right? Which again we will discuss HMP shunt. Because little bit you guys have studied in your class 11th and 12th also. So beta, what happens in HMP shunt? Ribose sugar is produced, right? Or if ribose is there, it is required for the synthesis of purines. Getting my point? I'll just explain this. So what happens is this glucose 6 phosphate instead of being converted to glucose, right, it undergoes HMP shunt, right? So increased concentration of this, increased HMP shunt will be there. So HMP shunt, why it takes place in the body? Because it leads to increased production of ribose sugar. And we know that ribosis is a precursor of purines. So I can say that purines synthesis will also increase. Okay, so if synthesis of purines increases, their degradation will increase. See, everything is stepwise. Increased concentration of glucose 6-phosphate is increasing HMP shunt. HMP shunt is increased, it increases ribose sugar. Ribose sugar increases, synthesis of purines increases. If synthesis of purines increases, synthesis of, yeah, you can say purine degradation also increases. And you know, when purines are degraded, uric acid is produced. So in a nutshell, I can say that uric acid will also increase. Right? And always remember that whenever there is increased concentration of uric acid, we call that condition as hyperuricemia. Okay? Uric acid, or it is hyperuricemia. Hyper means increased, uric acid in blood. Clear? So I will write it here that HMP shunt to purines, or simply I can say uric acid. So uric acid also increases, and this is known as hyperuricemia. Is it clear? So can I say that? Yes, beta, very good. Hyperuricemia leads to gout when there is pain in the joints. There is a restricted movement of the joints. So basically, gout is due to the increased concentration of uric acid. Or uric acid, from where it is coming? It is coming from the degradation of purines. Clear? And purines where ribose is synthesized, because you know this HMP shunt occurs in the body just because of one simple reason, that HMP shunt is the only shunt which can generate ribose sugar. And we all know that purines and pyrimidines are very, very important. They are the nitrogenous bases. They are required for the synthesis of DNA and RNA. Without them, molecular biology is nothing. So you can just imagine how the metabolisms are interrelated. Clear? So I can say that with von Gierke's disease, if a person is having deficiency of glucose 6-phosphatase, lactic acidosis is there, right? Hyperuricemia is there, hypoglycemia is there, hypertriglyceridemia is there, and ketosis is there. Okay, and that is why we always say that in von Gierke's disease, 3H are visible. So there are 3 hallmarks of von Gierke's disease. Triple H, 3 hallmarks. And what are these 3 hallmarks? Hypoglycemia, right? Hypertriglyceridemia. This terminology, if you are finding it a little bit difficult, you just dissect the words. Dissection of the words will make it more clear. Just say if I say hypoglycemia, hypo means decrease, glycemia is carbohydrate, mainly glucose, so decreased concentration of glucose. If I say hyper, more, glyceridemia, this is triglyceride, basically it is hypertriglyceridemia. Triglycerides, and triglycerides are nothing but the esters of fatty acid and glycerol, which is fat. Okay? Hypertriglyceridemia, and third one is hyperuricemia. So these are the 3 main important ones. and it will be fasting hypoglycemia. This is also very important, beta. There are different type of hypoglycemias. Slowly, जैसे so many hypoglycemias, ketotic are there, non-ketotic are there, fasting is there, normal hypoglycemia is there. So it varies from person to person. Fasting hypoglycemia is जैसे suppose whole night we are not having anything and morning में the concentration of glucose drops down. So that is fasting, means we are not consuming anything and our body is also unable. Why it is unable? Because glucose 6 phosphatase is absent, which is the main enzyme to give energy to the body in the form of glucose. And since it is present in the liver, it is a liver storage disorder. So obviously it is more serious. Yes, very good. Lactic acidosis is also there. I'm just writing that because triple H is there. So H, H, H. And these are the main biochemical investigations. Hypoglycemia, lactic acidosis, hypertriglyceridemia, ketosis, and hyperuricemia. Right? Now, since it is a glycogen storage disorder where in the liver, so there will be enlargement of the liver also. And whenever there is enlargement of liver, we call it as hepatomegaly. Right? Megaly is enlargement, hepato is liver. So when there is enlargement of the liver, it will be known as hepatomegaly. And second is it leads to renomegaly. Right? Reno means enlargement of the kidney. So hepatomegaly and renomegaly, these are the two main disorders which are actually due to the absence of glucose 6 phosphatase. Is it clear? Right? So now see, these are the biochemical investigations. Now what will be the clinical features? The most important clinical feature here will be, I'll just show you the image also of the child who is suffering from von Gierke's disease. Right? He will have doll-like face, I mean like facial features. Why? Because there will be the chubby cheeks. You can see that chubby cheeks are there. So we call them as doll-like faces. Why? Because there is increased concentration of the lipids. So fat deposition will be there. So increased amount of fat will be there, or we call them as TGs. Clear? And you can see there is enlargement of the liver also. So hepatomegaly will also be there. That is what I have written. So isko again there is a mnemonic for this. How you can remember this? You can say ki simple doll-like faces are there and HR. HR se yaad rakho hepato and renomegaly. And the most important thing is no splenomegaly is there. Right? So this is von Gierke's disease. The deficient enzyme is glucose 6 phosphatase because this is absent in the liver. But always remember beta, in normal individuals it is always absent in the muscle. Okay, but in particularly this disorder it is absent in the liver. So it is I mean like recognized by three hallmarks. Hypoglycemia is there, hypertriglyceridemia is there, and hyperuricemia is there, along with lactic acidosis and this you can say ketosis. Clear? So von Gierke's disease is type 1 A. Now, another disease related to this is type 0. Type 0, type O, whatever you can say. In type O or type 0, the deficient enzyme is glycogen synthase. Okay, glycogen synthase. So obviously, here the principal enzyme required to synthesize glycogen is absent. Clear? Yeah, thank you for the thumbs up, Animesh. Today, Dilkhush is not there in the class. Those students who are attending the sessions regularly, they actually, I should reward them with something, because Animesh is there, Vrishali is there, then Siddharth is attending the class for the first time, then I think Abhishek is there. They are all attending the classes on a daily basis. Then Alia is also there. Yesterday I think Alia was absent, but today she is present. But if you attend the sessions on a regular basis, you will never find a problem, any problem in this subject. Okay. So in type 0, the deficient enzyme is glycogen synthase. So obviously glycogen is not synthesized. So the storage form of glucose is not synthesized. So the energy, from where the infant will get the energy? Because if glycogen is not stored, there is no question of breakdown of glycogen. So the infant dies also. Infant dies due to lack of glycogen synthesis and degradation. Synthesis and degradation. Clear? Then similar to this is, जैसे ये type 1A है, another one is type 1B. जैसे von गिरकेस is type 1A, this is type 1B. 1B में क्या होता है? If you remember, yeah, Siraj was also there yesterday, I remember. Now beta type 1B में क्या होता है? When we discussed glycogenolysis, I told you that glucose 6 phosphate, when it is converted into glucose, right? Glucose 6 phosphatase is the enzyme. This we have discussed so many times. Up glycogenolysis is taking place in the cytosol. This enzyme is present in the endoplasmic reticulum. Endoplasmic reticulum. Okay, so what happens is this glucose 6 phosphate will be transported from the cytoplasm to endoplasmic reticulum, where this enzyme is there. So automatically glucose will be produced. Getting my point? So I can simply say that the enzyme glucose 6 phosphatase to convert glucose 6 phosphate to glucose is present in the endoplasmic reticulum. So this glucose 6 phosphate need to be transported. अब transportation के लिए बेटा, the most important thing here is, what is a transporter? A carrier protein, right? If this transporter is absent, then what will happen? Glucose will not be synthesized. So then type 1B is there. So I can say that in type 1B, the deficient enzyme is endoplasmic reticulum translocase. So the deficient enzyme is endoplasmic reticulum translocase. So obviously you can say again glucose will not be synthesized. So symptoms, if we talk about the clinical features, clinical features will almost be almost similar to von Gogh case. Right, but here there will be one more symptom, that will be recurrent infections will be there. The child will be more prone to infections, and that there will be a recurrence of the infections. Otherwise, the symptoms will be totally similar to that of von Gogh disease, but obviously the enzymes are different. Okay, so this is type 1A, type 0, and type 1B. Second, we come over to Pompey's disease or Pom's disease. Okay, so these type 1 or 2 act on which basis they are numbered. Like that only, beta. There is no specific reason ki why we are numbering type 1, type 2. It is numbered as such. There is no specific reason. There is no, I should say, scientific reason behind that. But yes, type 1A, type 1B are interrelated, and type 0. Okay, because I told you why type 1A and B are interrelated, because type 1A may the deficient enzyme is straightforward glucose 6 phosphatase, but in type 1B the translocase enzyme is absent. That's it. Clear? Then we come over to Pompey's disease or Pom's disease. So we can say it is type 2. Right. Okay, thanks for giving the thumbs up. Type 2. Up now, see, this is a very interesting disease in a sense that deficient enzyme here is, now beta, just now I told you that glycogenolysis also takes place in the liver and the muscles. Now coming over to the organelles, some part of glycogen is broken down in lysosomes also. Okay, say I can say 3 to 4%. So 3 to 4% of glycogenolysis takes place in the lysosomes. वैसे भी हम lysosomes को we call them as suicidal bags, or you can say they are the ones where actually digestion occurs, and they are the ones where once the proteins functions are over they are degraded. So they are the degradative organelles also. So glycogenolysis 3 to 4% takes place in the lysosomes. So Pompey's disease is the only lysosomal storage disorder. जैसे when we discussed mucopolysaccharidosis, they were all lysosomal storage disorders, right? Here only Pompey's disease, I'll mention it also, only glycogen storage disorder, which is actually a lysosomal storage disorder. And if we talk about the deficient enzyme, obviously since it is absent in the lysosomes, the deficient enzyme will be lysosomal acid maltase. Lysosomal acid maltase, right? So this is Pompey's disease. Now see, again lysosomal acid maltase is absent, so there will be accumulation of this glycogen again. So what are the main clinical features? First of all, this is a muscle storage disorder. Okay, so I can say that it is a muscle storage disorder. Means there will be something wrong with the muscle, right? And the most important muscle which is affected in Pompey's disease is the cardiac muscle. And what happens here is cardiac muscle. So there is cardiomegaly. Very, very important. Cardiomegaly is there. So obviously, if megaly, enlargement of the heart, तो ये क्या करेगा, जैसे heart is a pumping organ, isn't it? It pumps blood. when it becomes so big, it is difficult to pump the blood. Suppose if heart is say this is the vessel. If this vessel is this much, it will be difficult for heart to pump blood. So what will happen is, if the blood circulation decreases, automatically how much a person can survive? So the infant will survive maximum up to 2 years. After that, the infant will die. So in POMS disease, this is the most important. इसको learn करने के लिए देखो, simple criteria I can say, POMPs pump. ऐसे P for Pompey, P for pump. So the heart, who pumps? The heart pumps. If heart is unable to pump, so automatically it will lead to cardiac failure. Getting my point? Okay, my pleasure, Dr. Rajiv. Right. So I can say that cardiomegaly, it will lead to cardiac failure. Leads to and the infant can survive up to 2 years, that's it, and that too with great difficulty. Okay, and then hypotonia is there. Now what is hypotonia, beta? Tonia is actually the strength in the muscles, tonicity in the muscles, because muscles say we are doing work, we are anything we are doing, we are using the muscles, so the tonicity of the muscles decreases. Because simple hai, because the enzyme which is giving energy to that muscle, it is not functioning properly, so it will lead to hypotonia. Reduced tonicity, reduced tonicity of the muscle. Right. And then another important feature here is, which is again very very important, तो cardiac failure है, एक hypotonia, macroglossia. Right, macroglossia. What is macroglossia? Enlargement of the tongue. So you can just imagine, if the tongue enlarges, means the tongue shape of the tongue becomes huge, it is difficult to feed the child also. Okay, so difficulty in feeding. In feeding is there. So these are the important symptoms: cardiomegaly leading to cardiac failure, hypotonicity decrease in the muscular strength, and macroglossia, which leads to difficulty in feeding. And obviously, if the muscle is affected, exercise intolerant. The person will be totally intolerant to exercise. Matlab, whenever he starts exercising for some time, he will be tired soon. Right. And then you can obviously say, ये सारा तो हो ही गया. And the most important after this, acha, that I have written, infant can survive up to 2 years. And hypoglycemia will also be there. So these are the important features of Pompe's or Pomps disease. And this is the only disorder which is related to our muscle and lysosomes. Okay, so abhi just now we have covered von Gierke's disease, which is due to the absence of glucose 6 phosphatase, liver storage disorder. Second disorder which we read just now, it is Pompe's disease, which is a muscle storage disorder. Right, I hope till here it is clear. Then third disorder which we are going to take up after Pompe's disease is वो physics chemistry. Okay, so chemistry means Cory's disease. Right. Clear? So Cory's disease में what is the deficient enzyme? You can look at the table and tell me. Deficient enzyme is, फटाफट बताओ क्या हो जाएगा बेटा? चलो, I'll write. It is debranching enzyme. Right? Okay. So now after this we will take just 5 minutes break, and after break I will finish up with all the glycogen storage disorders. Right? So in this 5 minutes you can just relax for some time, and whatever I have explained you can just revise. Right? So see you guys after 5 minutes. Yeah. So let's start now. Okay. So if we talk about Cory's disease, the deficient enzyme here is debranching enzyme. Now again, what is the function of debranching enzyme? D mane removal. Kiska removal? Of the branches. So if you go back in glycogen synthesis only, I told you that this was glycogen. Okay. And this glycogen was converted into limit dextrins. And these limit dextrins were then by glycogen phosphorylase be converted into glucose 1 phosphate. If you remember. याद आया कुछ? Glycogen was first of all converted with the help of glycogen phosphorylase to limit dextrins. And here basically this debranching enzyme functions. ऐसे था ना बेटा, limit dextrins was this type of molecule 1, 2, 3 and 4. So this was then converted into linear chain and then glycogen phosphorylase used to act. Up in Cory's disease, this enzyme is absent. Right? So what will be accumulated? Limit dextrins will be accumulated. Right? Or debranching enzyme will be accumulated. Clear? So can I say that this Cory's disease is also known as limit dextrinosis? Yes or no? Getting my point? What I'm trying to tell you here is beta, Cory's disease mein the deficient enzyme is debranching enzyme. What is the function of debranching enzyme? It is simply removing the branches. So if it is absent, that means there will be accumulation of the molecule which has to undergo removal of the branches. That molecule is none other than limit dextrin. That is why Cory's disease is also known as limit dextrinosis. Clear? So it is what? It is a, first of all, muscle storage disorder. So here hepatomegaly will be visible. Right? Along with hepatomegaly, again there will be splenomegaly and no renomegaly will be there. Right? These are the three main important features, and obviously Cory's disease hai, so you can say hypoglycemia will also be there. Right? So this is type 3. So I can say Cory's disease as limit dextrinosis, or I can say it is type 3. Clear? Then after Cory's disease, then we come over to type 4, wo physics, chemistry, or. So or stands for Anderson's disease. Right? So in Anderson's disease, the deficient enzyme is branching enzyme. Yes, very good, Sandeep. Branching enzyme is there. So, if again I take you back to the synthesis of glycogen, you know, here synthesis of glycogen is taking place, and in Cory's disease, breakdown of glycogen is taking place. So, obviously, if branching enzyme is absent, it cannot incorporate branches, right? So if the branches cannot be incorporated, so what kind of structure will accumulate? Amylopectin will start accumulating. Okay, because branching is not there, so it is also known as amylopectinosis. And here basically again it is liver storage disorder. Okay, so I can simply write it is a liver storage disorder. So far whatsoever glycogen storage disorders we have studied, only Pompey's disease is the one which is related to the muscles, rest all are liver storage ones. ठीक है? So now what happens here is Anderson's disease में liver is the one which is affected the most. Now just imagine the condition of the liver, because there is amylopectin ka accumulation. So amylopectin is what? It is going to exert pressure on the portal vein. So what will happen is, because it is like a mesh of a structure, when it is exerting pressure on the portal vein will come under tension. So there will be hypertension of portal veins, or it will be so much that sometimes what happens is so much pressure is there. So there is, esophageal varices. मतलब क्या होता है कि हमारा जो esophagus होता है उसमें भी sometimes that bleeding also starts coming, and liver is the one which is affected, and it might lead to cirrhosis of the liver also. So I can say that what will be the clinical features? We can simply say increased portal hypertension, right, which leads to esophageal varices, right, and third is liver cirrhosis. So Anderson's disease leads to these main three symptoms, right? And this is again a liver storage disorder. Again, I'll just tell you one mnemonic. Mnemonic is A, B, C, D, E. A, B, C, D, E. Okay. A stands for Anderson's here. B stands for branching enzyme. That is what I told you. Anderson's is due to the absence of branching enzyme. C stands for Cories, and D stands for debranching enzyme. Right? So this mnemonic also you can remember. A, B, C, D, E. Clear? Then after Anderson's, then we come over. This was type 4. So वो physics, chemistry और then we come over to the next one, which is बेटा esophageal varices. मतलब क्या होता है कि when there is so much no megali in Anderson's, you can say beta hepatomegaly will be there. Okay, and animesh beta esophageal varices मतलब कि it's like, suppose if this is the vein, it is exerting so much pressure, because it's like a mesh is there which is accumulated. So what happens is so much pressure will be there, so that there will be bleeding, because it will try to rupture. It will rupture. That is esophageal varices. And there will be enlargement of this, because see, that is what I have written beta. A Sandeep liver storage disorder is there, so accumulation will be there, right? And Campylobacter, yes. After this I will come to this McArdle's disease. Now it is clear, Animesh? Then we come over to Conciliate type 5, McArdle's disease. So we can simply say it is type 5, right? Now coming over to the deficient enzyme here. This is a very interesting disease. The deficient enzyme here is muscle phosphorylase. Muscle phosphorylase. अब now see, the enzyme which is required to give energy to the muscles is absent. So what will happen? The most important clinical feature here will be exercise intolerance. Exercise intolerance will be there. The person will be totally intolerant to exercise, and again there will be muscular cramps also. Right? And then what will happen is, the most important feature here is that the color of the urine will change. Because what happens is, if the person is intolerant to exercise, cramps will develop, so there will be increased degradation of myoglobin. Okay, so there will be increased degradation of myoglobin. So basically it is also known as myoglobinuria. Right? So because of increased degradation of myoglobin, the color of the urine changes. So you can say urine is burgundy in color. Clear? So these are the 1, 2, 3, 4, 5 main features of McArdle's disease, which is a muscle storage disorder. And one more thing here, second wind phenomenon is present. I'll just explain it to you. Second wind phenomenon is present. Now, what is this second wind phenomenon? This is basically that phenomenon. Just suppose if you are getting fatigued after performing the exercise, if you are having a kind of fatigue, what you will do is you will just relax for some time and then again you will start performing the exercise. Okay, McArdle's disease means the same thing happens. You exercise, you get tired, but after relaxing for some time, you are able to perform the exercise again. Why? Because obviously that glucose 6 phosphate is there, then it will undergo lactic acid formation. Lactic acid will give energy to the fatigue muscle. Okay, so second wind phenomenon is present. The reason why I am telling you this, because this is the basic difference between McArdle's disease and Tarui's disease. Tarui's disease, which is type 7. Okay, so after this I'll just explain Tarui's disease. So McArdle's disease में the deficient enzyme you have to focus, it is muscle phosphorylase. And if I talk about Tarui's disease, right? Here the deficient enzyme is, what is the deficient enzyme here? Phosphofructokinase. Right, PFK. So I can say that Tarui's disease is due to the deficiency of phosphofructokinase. Now can anybody tell me what is the function of this phosphofructokinase? ये किसका एंजाइम है, किस पाथवे का एंजाइम है? Tell me fast, because we have discussed this enzyme in detail. Yes. Yes, very good, Animesh. We can call it as a pacemaker of glycolysis. Very good. We can call it as a bottleneck of glycolysis, because after this splitting up and this is the rate limiting as well as a rate committed enzyme of glycolysis. Clear? Up in Tarui's disease, phosphofructokinase is absent. Clear? So up clinical features iske same as McArdle. Exactly same as McArdle, means exercise intolerance, exercise intolerant, Okay. Then muscular cramps, everything is same. Third important is again burgundy color urine. Of urine. Now, the most important difference between McArdle's and Tharoi's is no second wind phenomenon is there. No second wind phenomenon is present. Right? So we can say exercise intolerant तो है ही है. Muscular cramps will also be there. Burgundy color because the increased degradation of myoglobin. But the basic difference is no second wind phenomenon is there. And just because of this, the condition becomes worst. The condition becomes worst if he or she takes fruit juice. Takes fruit juice. Why? Because fruit juice is rich in fructose. Up now see how it is correlated. A patient is having deficiency of muscle phosphorylase or he is having a deficiency of phosphofructokinase. Normally whenever we get tired after performing exercises, what we do is either we have a habit of taking either glucon D, glucon C, or you can say some other fruit juice. So let's not take it as glucose, we can take it as fructose. We know fruit juices are rich in fructose than glucose because fructose is more sweeter than glucose. So what will happen? Fructose will not be metabolized. Why it won't be metabolized? Because phosphofructokinase is absent. Right? Energy कहाँ से मिलेगी muscle को? Because the muscle should get energy from this way or the other way, from one direct way or the indirect way. If the direct way is absent, indirect way, it is making the condition more worse. So this is the basic difference between McArdle's disease and Tharoi's disease. In Tharoi's disease, the no second wind phenomenon is there. And if a person is suffering from muscular cramps and if he switches over to some fruit drink, the condition becomes more worst. Otherwise, rest of the symptoms will be similar to that of McArdle's disease. Right? So this is the difference between McArdle's and Tharoi's disease. Is it clear to all of you, beta? Clear? So I can say the basic difference, both are muscle storage disorders. If I have to say Tharoi's disease also is a muscle storage disorder and better this characteristic color is due to degradation of this myoglobin. Myoglobin is the one जैसे hemoglobin है. Hemoglobin क्या करता है? बाकी body में लेकर जाता है ऑक्सीजन. Myoglobin is responsible in the muscles. So energy कहाँ से आ रही है? That so there is degradation of this. Tharoi is type 7 beta 7. Type 6 is Her's disease. Abhi I have not explained Her's disease because Her's disease is a liver storage disorder. That's why I switched over to this. Okay, see, this is type, I'll just write, dekho, this is type 5, this is type 7. Type 6 is, I'll just write it here, Her's disease is type 6. Type 6. Getting my point, Sandeep? Yes. Tharoi's is type 7. Why I have written type, why I have explained type 7 before type 6? Because I just wanted to differentiate between Tharoi's and McArdle's. Both are liver storage disorders, but the basic difference here is see, both are having burgundy color, here also burgundy color, But difference is second wind phenomenon is present in McArdle's, not in Thyroids. Or in a nutshell, you can say Thyroid's disease is a kind of, I should say, harmful disease also, because the person cannot take fruit juice. If a person takes fruit juice, it deteriorates his condition because he won't get energy. So he cannot get up and start exercising again. But in McArdle's disease, he can. And animesh better, this characteristic color is due to reddish color. Reddish burgundy is reddish, brownish, copperish type of color because there is increased degradation of myoglobin. Because muscular cramps are there, na energy to chahiye muscle ko, so they will switch over to some other mode. Got my point? Is it clear, Animesh and Sandeep? Right. So the last disease is Her's disease, and Her's disease may the deficient enzyme is there. It was muscle phosphorylase. Here it is liver phosphorylase. So obviously the main clinical feature here will be hepatomegaly will be there, right? So these are the 6 glycogen storage disorders. Clear? And if I have to summarize them, I can simply say von Gierke's, right? Here I'll write POMS. After that, Corey's, Anderson's, McArdle, Tarui's, and Her's. These are liver storage and these are muscle storage GSDs. Right? Clear? And but this you have to remember because these are very, very important. Abhi to right now you are studying them in first year. When you are going to prepare for your PG, you know, these are the ones which are asked. These are the questions, frequently asked questions in the exam. Okay, and these are asked in the form of a clinical scenario also. Okay, a person visits you. I will be discussing certain clinical cases with you. A person, suppose if a person comes and visit you in your clinic, okay, his fasting blood sugar is say 40 or 50 milligram per DL. He is suffering from ketosis. He is suffering from increased concentration of triglycerides, right? So immediately you will see hypertriglyceridemia, ketosis is there, hypoglycemia is there, lactic acidosis is there, so he might be suffering from von Gierke's disease. So you can say that absence of this enzyme leads to this. So clinically also you can see and theoretically also you can solve. Clear? So now I'll just summarize all the glycogen storage disorders so that you can just go through this so it will be easier for you. Enzymes, chalo enzyme also I'll write. Right? So if we talk about, here I'll simply write the name. Here I will write the deficient enzyme and here I'll write the clinical features. Okay, so now let's start up with the first one, which is von Gierke's disease. Right? Deficient enzyme, glucose 6 phosphatase. Clear? If we talk about the clinical features, I can simply say hypoglycemia, right? Hypertriglyceridemia, hyperuricemia, right? तीन hyper हो गए. One is तो you get triple H. Then you can say lactic acidosis. These are the main features, right? And ketosis. Second is POMS disease. I can simply say lysosomal. So the deficient enzyme is lysosomal acid maltase, right? And the most important clinical feature for this is cardiomegaly. Very, very important. Cardiomegaly and hypotonia, because it is related with the muscle. And obviously macroglossia is also there. Macroglossia. Clear? Then moving on to the third one. Third one क्या है? Third is वो physics chemistry Cory's disease. So if we talk about Cory's disease, the deficient enzyme is debranching enzyme. Right. And if we talk about the features in Cory's disease, the most important one here is, can anybody tell me now? Anyone? Cory's disease may again I can simply say hypoglycemia will be there. Ketosis will be there. Or you can say hepatomegaly will be there. I forgot to change the color of the pen. Hepatomegaly will be there. Splenomegaly will be there. Right. And since there will be limit exinosis, so you can say here the enzyme also, liver enzymes also will be little bit changed. Then coming over to the fourth one is, yes, very good Sandeep, splenomegaly is there. Then fourth one is Anderson's disease. Anderson's disease mein the deficient enzyme is branching enzyme. So here I will simply write liver failure, or you can say liver cirrhosis will be there. Clear? And then comes McArdle's. McArdle's and Taru's, I'll write like that. Disease. McArdle's, the deficient enzyme is muscle phosphorylase. And the most important feature here is exercise intolerant, obviously. Excuse me. Then burgundy color of urine, very important. Burgundy color urine. Right? And the most important difference is second wind phenomenon is present. Second wind phenomenon present. Right. Then after that, then we come over to then after McArdle's, then is Hirsch's disease. And after this is Taru's disease. ठीक है? Hirsch's disease में what is the deficient enzyme? The deficient enzyme is जैसे here muscle phosphorylase, so it is liver phosphorylase. Right? And it leads to what? It leads to simple hepatomegaly. And if we talk about Taru's disease, the deficient enzyme is phosphofructokinase. And Taru's disease may same as McArdle's, but the basic difference is no second wind phenomenon is there. So this is all about the glycogen storage disorders. वो फिजिक्स केमिस्ट्री और मैथ्स में होशियार था. And here we finish up with the entire glycogen metabolism. So I can simply summarize the entire glycogen metabolism in glycogen metabolism in the form of a table like this. I can simply say that glycogenesis, right? And here I will just write glycogenolysis, right? Glycogenesis and glycogenolysis में difference is fed state, okay, fasting state, right? Anabolic, catabolic. Now, quickly tell me what is the rate limiting enzyme in glycogenesis? Now, I think you should be able to answer. What is the rate limiting enzyme in glycogenesis? Which is synthesis of glycogen. Chalo, I have given you this hint also. Quickly tell me. Yes, very good, Animesh. It is glycogen synthase. Very good. Okay. And rate limiting enzyme here is in glycogenolysis is beta. After this, we will be discussing gluconeogenesis. Uh, Glycogen phosphorylase. Very good, Animesh. Sandeep, beta, it is glycogen phosphorylase. Okay, see, since it is there now, I'll just try to, one second, I'll just try to explain you the difference. Sandeep, just pay attention here, beta. Dekho, this is glucose 6 phosphatase. Okay, and this is phosphorylase. Okay, I'll just write glycogen phosphorylase. अब बेटा देखो what is the basic difference between the enzyme glucose 6 phosphatase. एस का मतलब पता है क्या होता है? खाना, डाइजेस्ट करना. जैसे lipase is there, amylase is there. So glucose 6 phosphatase will digest phosphate. So digest करेगा तो it will form what? Glucose 6 phosphate will be converted into glucose. मतलब क्या है? This enzyme has taken up, it has eaten phosphate. Okay, and if we talk about glycogen phosphorylase, it also eats phosphate, but here the product is with phosphate. So if glycogen phosphorylase acts on glycogen, you know the product is always glucose 1 phosphate and glycogen will be N minus 1. So it is like it is phosphorylitic splitting. So we call it as phosphorylitic splitting. Okay, so that is why we always write the rate limiting enzyme of glycogenolysis as glycogen phosphorylase, not glucose 6 phosphatase. Because we are degrading glycogen, we are not degrading glucose. Got my point, Sandeep? Is it clear to you now? Because beta, enzymes are very important. Right? So if I am writing G6P, वैसे तो normally we write it like this. And suppose if I write the enzyme like this, G6, oh sorry, glucose 6 first. If I write the enzyme like this, you know, ये पता है क्या? It will be glucose 6 phosphate dehydrogenase. This is an enzyme of HMP shunt which we will discuss. Okay. So this is the main difference. Now, what I was discussing was I was just discussing the comparative thing. So glycogen metabolism में glycogenesis occurs in the fed state. This occurs in the fasting stage. It is since it occurs in a fed state, it has to be anabolic. It is occurring in the fasting state, it has to be catabolic. Here the rate limiting enzyme is glycogen synthase. Here the rate limiting enzyme is glycogen phosphorylase. And then the last but not the least difference we can say anabolic hai. So insulin promotes and here glucagon promotes. Right. And if glycogen is not converted to glucose, then different GSDs occur. Glycogen storage disorders occurs, which we have already discussed. So this is the entire summary. I'll just write here also epinephrine also increases it. Like this. So this is the entire metabolism of glycogen. So those who are first prof students, they can expect the questions like this. Explain glycogenesis in detail with regulation. Explain glycogenolysis in detail with regulation, because regulation is very, very important. This is what is regulation. And I told you insulin and glucagon act with the help of cyclic AMP. I hope this is all clear to all of you. Right? So here we finish up with our this topic, glycogen metabolism. After glycogen metabolism, we will be starting up with gluconeogenesis, that we are going to start up tomorrow. Right? So if there is no confusion, no question, shall we wind up the class for today? Thank you so much for attending the session. Yeah, thank you so much for listening to me patiently for approximately it's going to be 2 hours. And if again I'm telling you, I will be sharing this PDF just now on my Telegram channel, so you can just go through that all the notes, and if you guys have any problem, you can ask me anytime. Right? So wishing you all a good evening and a good day. Yeah. See you tomorrow, guys, at the same time. Okay. Yeah. Bye bye.